if you have any questions for me later also, if you're still struggling, catch me in the breaks.
Thanks so much, Puja, and to you and the team really for being so responsive. That's fantastic. So thanks for the, advance notice really of that really important review that you're leading. So there are a number of questions that have come in on the Slido, but before going to the questions, maybe I can just turn to Ronan and to Susan to see if they've got any sort of brief reflections. So I'll go to Susan first of all. Susan Mountain is the PPI contributor for AI Multiply.
It is important that we do that.
Can you just hold the mic close to you?
It is really important that us as the public have got trust in where our data is going. We should be involved in where the data is going for research, but it's also important as a member of the public, I want research to have access to data as well. So
Susan, just on that front, then there is a question that's come in. And the question is, how do we actually increase public trust? And the questioner asks, I think his mum is really apprehensive or suspicious about Alexa, for example. So how do we actually increase public trust? Do you have any thoughts on that?
Be transparent and see how our data is being used. The opt-out method is good. However, because I'm part of lots of researchers, I prefer the opt-out method not to be there.
Mm-hmm.
And for our data to be used, but just the basic data. Yeah.
Brilliant. Yeah, no, thank you. I think transparency,
Definitely
incredibly important. Yeah, brilliant. Thank you. Ronan, hope you're with us. Are you there, Ronan?
Yeah, I'm really sorry I couldn't be there physically, but I came back from India and became unwell and coughing and spluttering, so you don't really need what I've got.
Yeah,
but,
no,
delighted to be able to contribute.
Yeah, so Ronan is Professor of Public Health at Swansea. Has been a sort of a absolutely phenomenal figure in the creation of cell data bank and data infrastructures across the UK. So Ronan, wishing you better, and I'm doing a really poor job of standing in for you, but any reflections on what you've been hearing from colleagues?
Yeah, not at all. I think if I just address the last issue first of all about public involvement and trust in that. I've been fortunate over the years to have done many different data linkage studies, and we always actively engage members of the public in them. And right from the beginning, from the design to the dissemination, I remember once we did stuff on housing improvement to protect health, and members of the Llanelli Tenants Association were involved in that. And actually, they were there when the results came out, presenting them to the First Minister for Wales. And because we have a really active involvement of members of the public, we get very little criticism about using the data because we ensure we use the data for public good. Another point I would just make is I've often looked at all data sets have holes in them. And so eventually they all look a bit like Swiss cheese when we all want cheddar, which is a sort of solid block without anything missing. And we've got lots of different assets across the UK. And of course, as Cathie has mentioned, we're trying to sort of fill all of those in. But you can learn a lot by combining analysis across more than one set of data. Because very often you find there is another data set that can answer whether there's a bias present or not, or the size of it by actually looking at data from multiple environments. And I think we probably don't do that often enough. And I'll stop there.
Thanks so much, Ronan. So I've got, a series of questions here, and what I'll do is let's try sort of a quick fire response if we may. So maybe the first question for Puja, CPRD TRE, a really important development. When's it going to be available? How much is it going to cost?
So the TRE has been launched for single study license users. So if you are a new single study license user, you will be moved to the TRE. The pricing for that is available on the website. And what we had to work out was, because it will look more expensive, but that's because that was the traditional data access license cost, but now you have to pay for the TRE operating costs, which previously you wouldn't have seen because you would be using up your university's resources for that. So just a warning that, it's not coming to CPRD, it is the operating costs are passed through, but what we've tried to do is work with our users to get an understanding of what are your usage needs, come up with a package. It's almost like coming up with a mobile data package or something. We estimate, and then if you need more, you top up, but that seems to be the fairest way to distribute costs. For multi-study license holders, it is more complicated because we're still trying to work out, there was a lot we didn't see in terms of usage. So we're hoping the single study licenses teach us, but as a principle, we don't want the cost to go up by too much because we want the data to be affordable. You do research and that leads to public benefit. So I don't have an exact cost for the multi-study license, but it is going to, we hope to get multi-study license users up and running by October of next year.
Okay, thanks so much. I think there's a question somewhere here. Yeah, so please just introduce yourself.
Yeah, hi, I'm Lynn Laidlaw. I'm a patient public contributor, and I was struck by something that Puja said about not about bigger data, but better data. And you've all alluded to that. And I suppose I'm thinking, who decides what constitutes better data? And why should I give ever-increasing access to my data when I can't access it? For example, in Scotland, I can't access my primary care notes. What about some data allyship? So my question is, whose data is it anyway?
Okay, so whose data, how do we get better data? Who judges if the data are better?
I can explain how we define better data. So from our perspective as a data custodian who's making data available, we actually have a data quality advisory group, and they tell us so even simple things like, what is the format the data is coming in? Is it looking consistent? Are there some quirks? Like, for example, are there clinical records which are recorded for a person before they have that date of birth? So it's like little quirks like this that we look at. We also have we look at orphan data records. So it's from a research perspective, because that is our purpose. We make the data available for research with the input from the data quality advisory group, which includes a lot of academics who are working with the data. We decide what is it that we have to do as a data custodian for you, and also make it transparent to you how the data is coming, what are some of the quirks, so we have metadata. But it's not our role alone. So there's always going to be a responsibility for the researchers to determine what is good quality data, and for patients to inform in the context of a specific research study what is good quality data. And I think, Bruce, some of the things you said was because those are very research specific questions. We've been asked, why don't you put all these code lists on a repository? We can, but there's a caveat, because for my study, cardiovascular disease might be defined in a certain way and it's appropriate, but for your study, that may not be appropriate at all.
Okay, so Cathie, I see your hand. So I'm going to bring you in a minute because there's a couple of questions for you. But Bruce, how do you decide where data good enough, for example?
Well, I think all data has to be for its particular purpose. I suppose my challenge to data providers would be that actually there's a whole pile of stuff that could be pre-canned, but you still have access to raw data. And so for quite a lot of purposes, the pre-canning would just make life much more efficient. But you can have the raw data if you wish to vary that. I think in response to the original question, why, would, on average, patients being able to access their own data would make it more accurate, because they will pay more attention to it than I necessarily do when glancing at the record at the start of a consultation. And so, in England, that's reasonably easy. In Scottish systems, that's not easy. But with the new procurement, it should be straightforward in the future if people turn it on.
Okay. Ronan, do you want to come in there? And then I'll bring Cathie in.
Yeah, just to say, I want to agree very much with Bruce there about having the raw data as well as the pre-canned one, because phenotypes or algorithms are always created with a purpose, but they're very rarely spoken. So you may be answering different questions. But also why I think these are necessary. And I've conducted hundreds of different studies, right? And I've never got one right from the beginning. And often when we do some preliminary analysis, we think, hang on, that number seems too high, too low. What's gone wrong? And that's because there are hundreds, if not thousands, of different ways of coding things. And you have to take those into account. So it's extremely difficult to just run a black box algorithm and be confident that the relationships you're seeing are true. And I'll stop there.
Okay. So Cathie, maybe your thoughts on this, but there's also two specific questions for you. So the first is, review is clearly really important. How do we actually get it implemented? So I mean, maybe it's a bit of an unfair question at the moment, but that's one. And number two is, can you see any interplay with the forthcoming Darcy review, which we've been hearing about this morning and all over the weekend?
Yes, thanks for those. So actually, Bruce largely picked up on the issue I was going to raise about data. So what I think Lynn Laidlaw may have been driving at this is that patients, members of the public, are far more likely to feel comfortable about their data being used for a range of different research if they know it's accurate and represents what they believe to be true about their health. So exactly that point, that enabling access for patients where they wish to their own records so that they can query and help to correct them, but also learn more about their own health in a sort of much more meaningful way than is currently often the case, I think is part of this. So yes, to the other questions, implementation, obviously very important. Many reviews are written about many things, and they often sit on the shelf and gather dust. So, you know, someone who's spent a lot of time on this has been a bit like writing a PhD whilst doing a full-time job. You know, it'd be quite nice if one or two people at least read the executive summary and pay a wee bit of attention. But seriously, I think the process of writing a review is about the process of having the discussions and understanding what people think and kind of testing out ideas. So it doesn't sort of suddenly just get written. There's a whole process. So I think this is an ongoing process. Some of the things that I am recommending are already starting to be implemented because the conversations have been ongoing for some time. There's also the process of making sure that it lands as positively as possible with multiple stakeholders. So actually events like this, some of the briefing sessions I've been doing with stakeholders and other fora are really useful opportunities to test out the ideas in the review, to make people aware of what the recommendations are and make it more likely that the many different organisations and individuals who have to take this sort of thing seriously are more aligned and attuned. And then obviously there's the very important process of making sure that relevant ministers are briefed and understand what the recommendations actually mean in terms of the policy agenda. And my recommendations are, as you could see from that final slide, quite broad. There's actually quite a lot of flesh on the bones in the body of the report, and I've made some suggestions as to how they might be taken forward. But actually, it's kind of up to ministers and the organisations involved to decide how they take them forward. I think it's far more likely that there'll be a general agreement that they must be taken forward, and at some pace, actually, because of the way in which we're otherwise letting people down. So those are some of the mechanisms that I think will be useful in ensuring that some of these recommendations turn into real action and improvement. And then the final thing on the Darcy review. Yeah, so I don't know very much more about the contents of the Darcy review than you yourselves do, except that I suspect that there will be kind of components of it that pick up from the Times review of health that was released earlier in the year that I know Lord Darcy was involved in commissioning. But I think that it's very likely that that Lord Darcy will be be making some recommendations around the use of health data for deriving better intelligence and the health system as a system that generates data about itself and should be a true learning health system, and that those will be expanded on, and that the two reviews will kind of usefully help each other out, if you like. Obviously, my work goes into far more detail about the data side of things, and I'm sure Lord Darcy's review is going to be a much more all-encompassing, covering many more areas. But very welcome to hear views from the floor on those issues, Aziz.
Thanks so much, Cathie. I mean, I realise we're at time, but the kind of final couple of questions, one from the floor and one I've got here. So do you want to go ahead? Yeah.
Hi, I'm Benedict from Data Science at Evergreen Life. We've talked a little bit about code lists and defining the outcomes that we're all interested in looking at. And I feel like there's a degree of pessimism that you need to define a new list every time you want to do a new study. So you end up with, because there's so much nuance. But can you see a way forwards where you can perhaps unify that and not have to curate a new list every single time, or produce a method to better deal with that for researchers? Because quite often you need medical professions, clinicians, just to even understand the codes if you're not an expert in that area. So can you just comment towards that?
Chris, do you want to take that?
Yeah, of course. So work is ongoing to try and instantiate infrastructure on that basis. So it's really trying to mobilize the data that we've all spoken about today on that basis, in that you do not have to try and start from scratch every single time. I think, as Bruce alluded to, at the moment, there are probably too many codes out there to choose from, and therefore making that standardization from the start is quite difficult. But the idea would be that if you could at least point to a starting position for what a particular condition looks like in each of the nations of the UK, and how those codes map to each other, you've at least got a standard starting point. Unlocking the research code that has been used to generate that in the first place and then has been clinically validated and is very important through that peer review process will then allow people to have a standard starting point to then link left, right and centre, whatever they need to get those more complex elements sorted. But so that's work that HDR UK are doing, as Bruce and I have alluded to, but also the byproducts of the AIM consortia, for example, really need to be brought to the fore, I think, and shown to work across them, so that all of the good work is not just siloed, and it's not just the papers that come out of that, but it's actually the research artifacts being used for public good at the end of the day.
Okay, thanks, Chris. Bruce?
Yeah, I mean, I think, never make a code list without knowing how often the codes are used. When you look at code lists, you always think, oh, that's useless. But I mean, usually the things we argue about are things that are never used, make no difference whatsoever. And of course, rarely coded stuff, rarely used codes are probably more likely to be miscodes. So I think we actually spend loads of time on code lists when in reality, 95% of the data is the 5 most common codes. You might wonder why we need SNOMED. The reality is we can't cope with coding 100,000 read codes, so we choose high-level codes. Why do we need 800,000 codes? I mean, it's unlikely that practices, tiny organizations are going to be coding except at high level. So, yeah, I think we do waste a lot of time on it, which is why I think pre-canning would be useful. It's pre-canned, you can see what was done, you can decide if you want to use it, or you can step aside.
Okay, and final question, Susan, if I could bring you in, please. It's a bit of a complicated one, but the question is, there's a need for work using sort of the data sets that we've got around patients with dementia, for example, an increasing problem now, one of the leading causes of death in the country. How do we actually then communicate effectively back to people who are sort of cognitively, they're impaired with dementia? Do you have any thoughts on that? So where communication is really challenging, how do we do that?
It's a hard one now. If in the start of the dementia, I don't know, to be quite honest. How would you communicate unless it was through family? Yeah. Because family tend, my father-in-law had dementia, and the nurses and doctors tend to tell us, and then we communicated to him because he trusted. And I think sometimes people with dementia need that trust. Yeah. So possibly through the family.
I think it's a really helpful steer. So on that note, we're going to bring this session to an end. I think it's been an absolutely fantastic panel. So thank you so much. Thank you, everybody.